The pleura is the blanket that covers our lungs, and it's made of two layers, the inner visceral pleura and the outer parietal pleura. In between those two layers is a space. If air gets in that space, it's called a pneumothorax. Pneumothoraces can be classified into two broad categories, spontaneous or traumatic. Spontaneous pneumothorax is further subclassified into primary and secondary. A primary spontaneous pneumothorax occurs without a triggering event in an otherwise normal lung. Most commonly, an individual at risk of primary spontaneous pneumothorax is a tall, thin, young male presenting with symptoms that started at rest.
Hey.
This is because there are more mechanical shear forces at the apex of the lung that can make the pleura rupture, especially after, for some reason, holding their breath, like during diving, or inhaling and holding a recreational drug or medication in their lungs. Another risk factor for primary pneumothorax is smoking cigarettes and systemic syndromes like Marfan disease. Then, there's a secondary pneumothorax, that is, a spontaneous pneumothorax that occurs in a lung with pre-existing lung disease, like chronic obstructive pulmonary disease, or COPD, asthma, interstitial lung disease, tuberculosis, cystic fibrosis, or lung cancer. In COPD, destruction of the alveolar sacs leads to formation of large alveolar blebs, which are small balloons that can eventually rupture, leaking air into the pleural space. Traumatic pneumothorax occurs secondary to injury of the pleura after blunt or penetrating trauma to the chest, like a stab wound, or as a complication of a procedure, such as a lung biopsy, thoracentesis, central line insertion, or mechanical ventilation. Now, any pneumothorax, regardless of how it forms, can potentially become a tension pneumothorax, but it most often happens in a traumatic pneumothorax, which most often occurs due to a punctured lung. Causes can include a broken rib puncturing through the pleural space, or even after CPR. Tension pneumothorax is when the injured pleura forms a one-way valve allowing air to go in but not go out. This means that with every breath, the pneumothorax gets bigger and bigger. Now, in cases of a tension pneumothorax, it can compress the right atrium of the heart and the vena cava, decreasing venous return. This results in decreased cardiac output manifesting as hypotension, altered mental status, and an elevation of the jugular venous pressure, and this is typical of obstructive shock. In fact, because of the external pressure, sometimes the right ventricle can't move into the pericardial space, so the extra volume pushes the intraventricular septum toward the left. This leads to a reduction in left ventricular diastolic volume, a lower stroke volume, and a drop in systolic blood pressure during inspiration. A decrease in the systolic pressure of greater than 10 millimeters of mercury is called pulsus paradoxus. Additionally, in a tension pneumothorax, the mediastinum and the trachea may be shifted to the contralateral side. In terms of symptoms, a small pneumothorax may cause no symptoms, but typically a pneumothorax causes a sudden onset of shortness of breath and unilateral pleuritic chest pain, which is a sharp, knife-like pain that worsens with inspiration due to irritation of the parietal pleura by the expanding lung. It also typically causes tachycardia, tachypnea, or hypoxemia. Examination of the chest reveals decreased air entry or absent breath sounds on auscultation, and hyperresonance on percussion of the affected area. The diagnosis of a pneumothorax is confirmed by a chest X-ray, which shows a visible white visceral pleural line that's separated from the parietal pleura by pitch black gas. It's important to distinguish the pleural line from the border of the scapula on a chest X-ray. Additionally, the normal pulmonary vessel markings that branch from the hilum of the lung suddenly disappear beyond that visceral line. This is why we obtain these films during expiration, because when the individual breathes out air from their lungs, the lungs will shrink a bit, making it easier to detect even small pneumothoraces. Additional findings include flattening of the normally convex hemodiaphragm and deepening of the costophrenic angle, which is the angle between the pleura covering the ribs and the pleura covering the diaphragm. In secondary spontaneous pneumothorax, other findings of underlying lung disease will be present, such as hyperinflation in COPD. Now, in a non-tension pneumothorax, you may also see mediastinal shift toward the side of the pneumothorax, while in a tension pneumothorax, mediastinal shift will be away from the pneumothorax. Now, initially, all patients with a spontaneous pneumothorax are put on supplemental oxygen, even if they're not hypoxemic. The idea behind this is that the air in both the alveoli and the pneumothorax is mostly composed of nitrogen, about 78% nitrogen. So, by giving oxygen, we make the alveolar air mostly contain oxygen with very little nitrogen. This increases the nitrogen gradient between the pleural space and alveoli. So, nitrogen in the pneumothorax will just diffuse from the pleural space to the alveoli, allowing the individual to essentially breathe most of the air in the pneumothorax right out. Alright, now the subsequent steps of management depend on the size of the pneumothorax on chest x-ray, and the stability of the symptoms. Definition of stability must include a respiratory rate lower than 24 breaths per minute, a heart rate between 60 and 120 beats per minute, a normal blood pressure with cutoff values that are not established, room air oxygen saturation higher than 90%, and have the ability to speak in whole sentences. If any of these characteristics is not met, the individual is considered unstable. Starting off from primary pneumothorax, it is considered small when it's less than 3 centimeters distance between the pleural line and the chest wall at the level of the apex, or less than 2 centimeters between the pleural line and the hilum. Stable individuals with a small primary pneumothorax can be safely discharged, with a follow-up x-ray 1 to 2 weeks later to make sure the pneumothorax is gone. On the other hand, if the individual is stable but the pneumothorax is large, then a pleural aspiration with needle thoracentesis is performed. This involves inserting a small bore needle or catheter into the chest to aspirate the air in the pleural space. Now, it's important to insert the catheter above the rib to avoid damage to the intercostal vein, artery, and nerve, or the vein running below the rib. If pleural aspiration fails, then a thoracostomy or chest tube is inserted. Finally, all unstable individuals must be immediately treated with needle thoracostomy, which uses a larger bore needle than needle thoracentesis, allowing more rapid decompression of the chest cavity. Alright, moving on to secondary spontaneous pneumothorax. Similar to primary spontaneous pneumothorax, supplemental oxygen is given to all patients, and subsequent management depends on the size of the pneumothorax and the stability of the symptoms. But the difference is that the thresholds are lower because this individual already has underlying lung disease. If the pneumothorax is small, so less than 2 centimeters distance between the pleural line and the chest wall at the level of the apex, and the patient is stable and completely asymptomatic, or with minimal symptoms, then the patient is usually admitted for 24 hours of observation. Now, if the individual has a small pneumothorax and is stable but presents with significant symptoms, if they have a large pneumothorax, or if they're unstable, then pleural aspiration with needle thoracoscopy is done. Finally, it's notable that both primary and secondary spontaneous pneumothorax tend to recur, but because of the underlying lung disease, secondary pneumothorax recurs more often. Therefore, if an individual has their second primary or first secondary spontaneous pneumothorax, or has a spontaneous pneumothorax that isn't disappearing following chest tube insertion, then surgical intervention can be considered, since the chances of recurrence progressively increase with each new pneumothorax. It's also important to always surgically intervene in individuals working in a high-risk occupation that subjugates them to large changes in atmospheric pressure, such as a scuba diver or a pilot.
We hope you enjoyed the flight, and have a nice day.
The main surgical option is pleurodesis, which is obliterating the pleural space, so the air can no longer accumulate. This procedure can be performed by introducing chemicals like talc, silver nitrate, or the antibiotic doxycycline through a chest tube. These chemicals induce an inflammatory response that eventually results in fibrosis, effectively sticking the visceral and parietal pleura together. Another option is mechanical pleurodesis, in which a surgeon enters the lung using video-assisted thoracoscopic surgery, or VATS. Once in the pleural space, the surgeon repeatedly rubs an abrasive tool against the pleura, inducing fibrosis. Now, attention pneumothorax is a clinical diagnosis, meaning that if it's suspected based on symptoms and presentation, the diagnosis doesn't need to be confirmed with a chest x-ray. Rather, it's a medical emergency that must be immediately treated with needle thoracostomy, by inserting a needle in the second or third intercostal space at the midclavicular line, decompressing the pneumothorax. To confirm decompression, the individual's breathing will improve, and you might even hear the air escaping. It's usually pretty dramatic. Following decompression, a chest tube is inserted in the fourth or fifth intercostal space along the anterior axillary line. Now that the patient is properly breathing, you can breathe too, and get that chest x-ray. It's also important to address the tension pneumothorax before intubation, and that's because mechanical ventilation can worsen a tension pneumothorax. That's because you're supplying air that's under positive pressure, basically adding fuel to the fire. Alright, as a quick recap. Pneumothoraces can be broadly classified into spontaneous and traumatic pneumothorax. Individuals present with sudden onset shortness of breath and pleuritic chest pain. The diagnosis is confirmed with an expiratory chest x-ray. The management depends on the size of the pneumothorax and the stability of the symptoms, ranging from simple observation to pleural drainage and chest tube insertion. Due to their recurrence, chemical or mechanical pleurodesis can be done, effectively obliterating the pleural space. Finally, a tension pneumothorax often occurs in the setting of chest trauma and can potentially result in cardiovascular collapse. Therefore, once a tension pneumothorax is recognized by signs like elevation of the jugular venous pressure, tracheal shift, and hypotension along with the symptoms of a pneumothorax, immediate needle decompression is prioritized over obtaining a chest x-ray.